Good morning everyone. So today we'll be learning about septic arthritis. So septic meaning is infection, arth meaning is joint, and itis means inflammation. Septic arthritis is basically the inflammation of the joint. So whenever we talk about septic arthritis, we need to understand that the most common age group affected, who is being affected by septic arthritis, is basically the children. And in children also, it's basically the infants. Why infants? Because the growth plate has not formed yet, and the infection from the bone can actually go into the joints. Okay, so that doesn't mean septic arthritis doesn't occur in adults. It does occur in adults in the case of intra-articular injections of steroids, like in the case of whenever you have some joints problem, maybe rheumatic arthritis or osteoarthritis, and you go for an intra-articular injection, but that is not sterilized in a well way, so that can also lead to septic arthritis. So we'll go on to the different etiology, we'll go to the pathophysiology, the treatment of septic arthritis. So let's talk about septic arthritis. See, septic arthritis is a medical emergency. Sepsis is itself a medical emergency, and we have to intervene it in time. Else what can happen? The patient might land into septic shock, leading to hypovolemia, and ultimately cardiac arrest of the patient. So we need to be really careful when someone presents with history of septic arthritis. Now, what would be the history? I'll just give you a generalized feature, and then I will go on to the different slides. Okay. So whenever a patient comes with septic arthritis, the major presentation is the position of ease. So what is the position of ease? The position of ease is flexion, abduction, and external rotation in the case of hip, and it is 5 to 30 degrees of flexion in the case of knee. So this area, basically the hip and knee area, are much more prone for septic arthritis. Your shoulder joint may also be involved, elbow may also be involved, the major one being the hip. First the hip and then the knee. Okay, so any kind of septic arthritis, if it occurs in the hip below less than 1 year of age, and that is known as Tom Smith arthritis, and that Tom Smith arthritis is usually seen in infants. Okay, so inflammation of the synovial membrane with a purulent effusion into the joint capsule due to effusion. This word itself, clearly defines the septic arthritis. And what you need to remember is, whenever there is pain in septic arthritis, it's not because of the toxic products that is being liberated. It's because of the extension of the joint capsule. It's similar in the case of like transient synovitis also. The most common differential diagnosis of septic arthritis is transient synovitis, and transient synovitis is following a viral infection. It is not actually an infection, it's following a viral infection. It's basically due to release of excessive synovial fluid into the synovial space that causes stretch and that causes pain. Here the pain is because of the stretch of the infective material. Because of that exudates, there is a stretch, and because of that stretch there is pain. Okay, there is no pain whenever there is a destruction of the cartilage. Remember, that is why osteoarthritis is also a misnomer. Okay, osteoarthritis means there is not inflammation, there is pain, but that pain is because of the dropping of bone in the case of osteoarthritis. Okay, in the case of septic arthritis, this pain is because of the stretch of capsule. Okay, so never say the pain is because of the destruction of the articular cartilage, because cartilage are avascular. The cartilage are all-neural. Okay, they are all-neural, they are all-lymphatic, they are all-neural structures. Okay, and of course they are avascular because they get their nutrition from the synovial fluid. Okay, this cartilage. Now, this is also known as infective arthritis. It's a medical emergency known as sepsis. Now, failure to initiate medical or surgical interventions can lead to joint destructions. I want to add upon two things here. We need to understand about fibrous ankylosis and bony ankylosis. So, whenever we talk about these type of ankylosis, moreover, in the case of septic arthritis, there is fibrous ankylosis. In the case of, whenever we talk about bony ankylosis, any type of TB can lead to fibrous ankylosis, except for the spinal cord TB that leads to bony ankylosis. Similarly, rheumatoid arthritis leads to bony ankylosis. Okay, so here it's fibrous ankylosis. So we'll come. Ankylosis is basically fusion of the joint. Okay, and there is one term, arthrodesis. Don't be confused between ankylosis and arthrodesis. Ankylosis means infective origin, inflammatory origin, and because of the pathology, the joint has been fused. Arthrodesis means I'm iatrogenically, surgically I'm fusing the joint, and triple arthrodesis is a component of your CTV. So I'm explaining all the things, correlating everything. So just see, knee joint, hip joint, shoulder joint. Oh, I'm sorry, it's the knee joint. Okay, 50% of the cases it's the knee joint. But these are the most important joints: the knee joint and the hip joint. Okay, shoulder, elbow, ankle can also be involved, but the major one being the knee and the hip joints. Now next slide. So I already told you that it's more common to children less than 3 years and more than 80 years because it's an immunocompromised state. Okay, it's more common to males than females. It's more common in the prematurity. It's more common due to invasive procedure. I already told you about the intra-articular injections that you use in the case of rheumatoid arthritis or osteoarthritis or any kind of pain in the joints, right? Diabetes is itself an immunocompromised state. Rheumatoid arthritis, immunocompromised, IV drug abusers, alcohol. All the risk factors are basically of osteomyelitis. It's the same thing. When there is bone infection, that infection from the bone can actually transfer into the joint by the growth plate. Okay. So we have already talked about this. This is a simple thing. The same thing in osteomyelitis and as well as in septic arthritis. Extension from the adjacent bone from the osteomyelitis, as I initially told you, right? Hematogenous because of URTI. You know, Haemophilus influenza, Klebsiella. These are the basic organisms. Streptococcus pneumoniae are the basic organism that causes upper respiratory tract infections. So any child who might present to you in the orthopedics department, why no? You know why? If you have interest in orthopedics, you should also know ENT. You should also know ophthalmo. Why is this important? Because any patient who comes to the orthopedics department might also have a complaint of earache because of URTI. Because of URTI, he might be suffering from acute otitis media also. So you need to know everything, okay? It's not like you just know orthopedics. So direct inoculation into the joint by the trauma or certain surgeries. So iatrogenic can also be there, okay? Now pathophysiology, as I already told you that there is a destruction of the articular cartilage. This destruction of the articular cartilage is basically because of the inflammatory exudates and the release matrix metalloproteinase. So you can see here, release of proteolytic enzymes like matrix metalloproteinase from the inflammatory cells. Cell cartilage and synovial cell, they get damaged, and because of that damage there's continuous rotting of the bone and that leads to ankylosis. Will come in the coming slides. Right now, see, I told you the organisms initially, 3 basic organisms: Streptococcus, Haemophilus, Klebsiella. Never forget it, okay? So these are the list of the organisms: Haemophilus, Streptococcus. But whenever you talk about osteomyelitis induced septic arthritis, never forget Staphylococcus, because joints won't Staphylococcus. And if in case the patient has a history of latest, like previous history of maybe diarrhea or maybe history of typhoid, then you have to also rule out diaphyseal osteomyelitis, which is basically caused by salmonella. Okay, so salmonella is the only component which causes diaphyseal osteomyelitis. Whether all osteomyelitis is metaphyseal. Please remember, this is an MCQ question. Next is, see, there is this term I just want to highlight, the pseudoparalysis. See, whenever patient comes with pseudoparalysis, the most common 3 differentials that should come into your mind is: one is septic arthritis, other one is scurvy, and other one is osteomyelitis. Okay, so pseudoparalysis means actually it is not paralyzed, but because of pain the person is not able to move his limb. Okay. These are the generalized features like decreased appetite and tachycardia. Whereas there is febrile, there is pain, there is limb. Okay, as I already told you, the position of ease. Never forget position of ease. 5 to 30 degree in the flexion in the case of knee, and Faber, flexion, abduction, and external rotation in the case of hip. Now, you can see in physical examination, you can see localizing temperature. The physical examination basically means you just look into the joint. Okay, so it involves inspection, palpation. Okay, inspection, palpation, and movement. Okay, in the case of orthopedics, inspection, palpation, and movement. Is not able to perform any movement because of pain. Simple, very easy, one-liner. Okay. Secondly, inspection. When you inspect it, it looks red, erythematous. There might be certain bulging, certain edema. Okay. Same thing, localized tenderness. When you touch it, there is localizing temperature. Okay, and I already told you position of ease. 5 to 30 degrees in the case of knee, flexion, and Faber in the case of hip. There is no range of motion. If in case, I just want to one more thing I just want to add up over here. Whenever there is bony ankylosis, you know, bony ankylosis, in bony ankylosis the person is not able to move, is not able to move at all, because of which pain will be less as compared to fibrous ankylosis. Because in fibrous ankylosis, just fibrous tissue, fibrin meshwork. because of which he can go for slight movement, and even slight movement causes massive pain. That is the logic. Now, of course, we can go for laboratory investigations like increase in the ESR and CRP. We can go for blood culture. Of course, we'll see different organisms, as I already explained in the previous slides. So you can see here the normal joint space and the loss of the joint space that you can see in the case of septic arthritis. Okay, so why is there loss of joint space? Because of the destruction of the arterial cartilage, and there is a dropping of bone. Okay, the bone comes towards each other, and because of that there is a loss of joint space. And there are different conditions where there is loss of joint space. So this is not just the diagnostic. The diagnosis will be MRI. Okay, the diagnostic will be MRI to look into the fluid that is being that is there inside the joint, to look into the stretch of the synovium. Okay, just go for an MRI. So you can see here narrow joint space, loss of cartilage. See, loss of cartilage basically it's also one of the component of your osteoarthritis. In the case of, like you say, like joint mice, rice bodies. Okay, these are the different pathological terms that we use in the case of osteoarthritis. And you can also see here, but cartilage is a radiolucent structure, not an X-ray. Just go for an MRI in the case of definitive diagnosis. Okay, but we can diagnose this clinically also. Okay, by history. So you can go for USG for Epstein confirming joint effusion in large. MRI detects joint effusion and may detect adjacent bone involvement such as osteomyelitis. MRI is gold standard. It's very helpful. So CT scan not preferred because ossification centers, this ossification centers develops late, and sometimes there's a confusion pattern. So USG and MRI is the best. So you can see here, this chart shows synovial fluid analysis. I won't go towards the total detail, just towards the conclusion of this synovial fluid analysis. You need to remember, in the case of osteoarthritis, there is a clear yellow fluid, and in the case of septic arthritis, there is purulent. Why purulent? Because of infection. Okay. Normally, there is also it's clear yellow. Normally, it's clear yellow. Now, why the normal and the osteoarthritis same? Because osteoarthritis, there is no infection. It's not an infective condition, isn't it? But in the other conditions like pseudo-gout, gout, or rheumatoid arthritis, it's cloudy. Okay. And in tuberculosis, it's turbid. We have already, we have studied in your microbiology about different types of media, like Lawson Jensen's, meat and brew. Okay. These are the different medias where you can cultivate. So we don't want to go here. We are mainly focusing on septic arthritis. Now this is cautious criteria. Now why is cautious criteria important? I already told you that septic arthritis, the most common differential diagnosis is transient synovitis. So I want to differentiate transient synovitis from septic arthritis, right? So I'll just go for a cautious criteria where I'll see temperature more than 1.3 degree Fahrenheit, white blood cells more than 12,000, erythrocyte sedimentation rate more than 40, and inability to ambulate, and C-reactive protein. But the major one is being this 3: temperature, white blood cells, and erythrocyte sedimentation rate. Sorry. So just remember cautious criteria. This is moreover reading things, so I don't want to waste much more time over. Now let's come to the treatment. So remember, in examination, whenever you write about treatment, write about first of all general treatment and then go for a specific treatment. Of course, we know the specific treatment is giving an antibiotics, right? IV antibiotics. So how long are you going to give this antibiotics? You are going to give this for 6 weeks. Okay, 2 weeks. 2 weeks you'll give IV antibiotics, and 4 weeks you'll give oral antibiotics. Now, why this long course of antibiotics? Because bone penetration of antibiotics is quite low. Okay, so we use antibiotics like flucloxacillin and fusidic acid. Okay, and general features like, for example, the patient might be dehydrated, the patient blood loss may be there, or maybe the patient is dull. Okay, so you have to just go for ABCD management if in case it's an emergency. I already told you this is surgical emergency, right? So ABCD protocol is very important, so you should write that in every answers. Now for specific management, you can go for IV antibiotics. It's written 3 to 4 weeks as oral, but the major one is 6 weeks. Just remember 6 weeks. 2 weeks IV and 4 weeks oral. Okay, 2 weeks IV. First IV antibiotics, and then post-operative give oral antibiotics. It's written in that way. Okay. Now arthrotomy, joint irrigation and drainage can be done. Okay, we'll just wash out everything in the joint. We can go for splinting. Why splinting? Because we just want to reduce pain. Okay, the work of splint is to reduce pain. Next is immobilization up to 6 weeks, gradual range of motion, and check ESR and CRT. So these are actually the prognostic markers. So as soon as your ESR decreases, the CRT is being decreased, and that's a good prognosis. Okay. So of course I told you what is the different sequelae of this disease if not treated. It can lead to bone destruction of the joint, ankylosis, cartilaginous destruction, fibrosis. Okay, it's written of fibrosis of bony ankylosis, the major one being fibrous ankylosis in the case of septic arthritis. But bony ankylosis in the case of TB spine and other conditions like your rheumatoid arthritis. Okay.
Osteoarthritis too.
Osteoarthritis, I'm not sure about it. I have to look into it. Okay, so but here it's fibrous ankylosis. Okay, in adults, partial destruction of the joint will result in secondary osteoarthritis. Growth disturbance, of course, if it involves the growth disturbance, and of course there is a shortening of the bone. Okay, now it's just a pattern. So thank you so much.
Okay, thank you, sir.
Thank you.